Thank you for joining us today. I'm Shelley Fuld, Nasso, CEO of the National Coalition for Cancer Survivorship. Yesterday, the United States passed a grim milestone of 500,000 Americans who've died from COVID-19. We're approaching the one-year mark from when shutdowns began. Last week, we learned that life expectancy for Americans fell by a full year during the first half of 2020. But that doesn't tell the whole story. The drop in life expectancy was 2.7 years for Black Americans and 1.9 years for Latinos. But there is good news. Cases and the death rate have begun to fall. And as we all know, 2 vaccines were approved last year, and a 3rd vaccine is under review by the Food and Drug Administration. As of yesterday, the Centers for Disease Control and Prevention reported that 44 million people have received at least 1 dose, and 19.4 million people are fully vaccinated. The CDC guidelines for phase 1C include people ages 16 to 64 with underlying medical conditions. States have leeway to implement the guidelines as they see fit, and some states do include cancer patients, but supply continues to be a concern. In a letter last month, NCCS joined with the Cancer Leadership Council to urge the Advisory Committee on Immunization Practices, or ACIP, to review the data related to the risks that COVID-19 poses to cancer survivors as they monitor and update the immunization schedule and to evaluate states' flexible use of the schedule. We know there is a lot of concern among cancer patients and survivors about the vaccine, the science, the effectiveness of different vaccines, interactions with cancer treatments, and many others. We are grateful to Dr. Otis Brawley for joining us today to answer our questions about the vaccine as it relates to cancer patients and survivors. Dr. Brawley participated in our first COVID webinar last April in the early days of the pandemic. He's a Bloomberg Distinguished Professor at Johns Hopkins University, an oncologist and an epidemiologist. And he explains complex issues in a way that non-scientists can understand, and we really appreciate his willingness to share his expertise. We have received many questions for this webinar, some that are very specific to a diagnosis or treatment and many that are overlapping. We've tried to consolidate and generalize some of the questions, and we will get to as many as we can. And you can still submit questions in the Q&A box in the Zoom application. But first, I'm going to turn it over to Dr. Brawley to make some opening comments before we begin with the questions. Dr. Brawley?
Thank you. It is really a privilege to be here, and thank you for asking me to come back. February the 23rd of last year, there were a total of 32 people in the United States who had coronavirus, and we had at that point recorded no mortality whatsoever. We later went on to find out that there had been some deaths in January of last year in the United States, but still, it was a very measured problem at the time. It was a huge problem in Wuhan, China. It was a burgeoning problem in Europe, but things seemed under control in the United States. Today, we have 500,000 deaths. To give you an idea of how significant that is, we are 4% of the world's population, but now 20% of the world's coronavirus deaths. The disparity started the epidemic started in large cities in Seattle, New York, spread to other large cities like DC, Chicago, New Orleans, Detroit, and then started getting into the suburbs and into rural areas. And we've heard about waves over the last year as more and more people have gotten sick. Thankfully, vaccines were developed very quickly, and I should point out they were developed because of technologies developed in the last 50-year effort in the war on cancer. Many of the scientific technologies led to the ability to sequence the virus. The first 2 vaccines are RNA vaccines. RNA vaccines were first developed as a cancer treatment. We've not seen benefit from cancer treatment yet, but we've seen benefit in terms of coronavirus. The risk to cancer patients has now been quantified. People who have solid tumors who are not being treated right now, their risk of having bad outcomes from coronavirus are very similar to people of the same age who do not have cancer. Unfortunately, the risk for people who are under therapy and the risk for people who have hematologic malignancies is more serious and much more problematic. We've got several vaccines from Moderna and Pfizer, which are now being widely distributed, as Shelley just noted. The Johnson & Johnson one-dose vaccine, which doesn't have to be frozen to extreme temperatures. You can store it in a normal refrigerator. Is hopefully going to be approved by the FDA over the next 2 to 3 weeks. We'll talk a little bit more about that because some people are a little concerned that they heard it was 65 to 70% effective. And the question is, would you want the Moderna or Pfizer vaccine, which is advertised as 95% effective? Please keep in mind, they were tested at different times in different places. So we don't know that Moderna 95% effective right now. The Pfizer and Moderna virus were not tested in areas that had the mutations that we've heard about from the UK or from South Africa, whereas the J&J virus vaccine was tested in populations that had some of that ongoing. J&J is also one dose, easier to give and also easier to store. I have worried a little bit that some of the thawing out of the Moderna and Pfizer vaccine, which is sometimes done under the not the best controlled circumstances, might even neutralize some of the vaccine. We are going to, by the way, have more mutations in the future. Hopefully we can get rid of this virus as quickly as possible so that we can stop the mutations. If we can kill the parents off, we can stop the progeny. The way we stop progeny is still very basic Tony Fauci, social distancing, masking, hand washing. We're, I believe, going to be in an era where we're going to have to be masking until the end of the year, maybe well into early next year. Then some improvement, I should point out, in the treatment of coronavirus among people who have them. Monoclonal antibody therapies have been developed. They're based on convalescent plasma, taking plasma from people who've got over coronavirus and giving them. The monoclonal antibody therapies are here, they're working, there's high availability, there's not a shortage. Remdesivir, which interferes with RNA replication, is getting more widely available. The steroid Decadron, very commonly used to treat a number of malignancies, is useful. Interestingly, tocilizumab, which is an interleukin-6 inhibitor, used to treat some malignancies as well as rheumatoid arthritis. It's actually a drug that you can see an advertisement for it on television for rheumatoid arthritis. It is very useful in treating people who are incredibly sick and in intensive care units. And some things that we've even learned are lying prone when one is sick, the respiratory version of this disease. All of those things are helpful. I want to go back to social distancing, masking, and hand washing, and trying the distancing especially. The people who've been hardest hit by this pandemic are people who have not been able to practice social distancing because of work requirements, or people who haven't practiced them because they just haven't taken the pandemic seriously. We've had 500,000 deaths, and the value of social distancing, masking, and hand washing can best be summed up with, if we were France today, and if we had done what they did in France, it would be 410,000 deaths instead of 500,000. If we're Germany, there'd be 270,000. Canada, 194,000 in lieu of the 500,000. And the difference between these countries are taking these measures, social distancing, masking, and hand washing, as seriously as possible. So I'll stop at that point and maybe we can go into the questions that people have.
Great. Thank you so much, Dr. Brawley. I want to start with just taking a step back from the vaccine, but just looking at risk. So what is it that makes cancer patients at higher risk? Is it the cancer itself or the treatments for cancer? And if it's the treatments, which treatments make patients more vulnerable to COVID?
Okay. The people who are at risk for contracting the disease are people who have a lowered immune system. Now, that lowered immune system can sometimes come about because of cancer treatment. Say people who have solid tumors, colorectal cancer or breast cancer, their immune system is relatively intact. When we start giving them chemotherapy, their immune system is damaged. That's one of the side effects of treating the cancer. People who have lymphoma and leukemia, on the other hand, that's a cancer of the immune system. Their immune system has a problem to begin with. And so the approach to coronavirus should be different between the two. We have a lot of data to show that people who have leukemia, especially who coronavirus, are more likely to have bad outcome. Most people do well, but they're more likely to have bad outcome compared to the people who have solid tumor disease. People who have solid tumor disease or cured are at essentially the same risk as people who are of the same age and basic health. But people who have treatment. Now, people who are getting treated with drugs that specifically target B cells that make immunoglobulin are at especially higher risk from coronavirus. B cell treatments are common in leukemia and lymphoma.
Okay, so given that, should certain cancer patients be given priority for vaccines over other cancer patients?
One of the problems, and this is very disconcerting, dissatisfying for me, is we don't know for sure how well these vaccines are going to work in certain cancer patients. The guess would be people who have solid tumors who are not getting chemotherapy. The vaccine is going to work just as well as it would in someone who is not having cancer. But people who have diseases of their immune system, will the vaccine work or not? We don't know. My advice is to try to get the vaccine, but one has to place the vaccine in one's therapy such that one doesn't get a therapy that keeps your immune system that is working from responding to the vaccine. Every person's going to have to talk to their doctor about their specific circumstance. There are some instances where there's some people who are under therapy and they should not get the vaccine right now. They should continue their intensive therapy against their leukemia and lymphoma. And then there's some folks who are in other phases of their therapy where they may want to get the vaccine in between scheduled doses of chemotherapy, or maybe even extend one session of chemotherapy out a little longer so that they can get the vaccine, have the initial response to the vaccine. We are especially this is going to change a little bit if the Johnson & Johnson vaccine is approved. I really do anticipate that the J&J vaccine is going to be approved by the FDA within the next week to 2 weeks. It's a one-dose vaccine, whereas Moderna, you have to get a booster shot 4 weeks after the first. Pfizer, the booster shot is 3 weeks after the first. And so that means that people would have to jockey and move around chemotherapy twice to get Moderna or Pfizer. It's only going to be once with the J&J vaccine. By the way, in the offing, we also may have an AstraZeneca Oxford vaccine. That vaccine is in development, but the FDA has already told them they need to go back and do some additional testing before it will be approved here. It has been approved already in Europe.
Okay, so what about survivors who've completed treatment? Are there any certain treatments that they may have had that keep them at higher risk, even years or months after they've completed treatment?
I'm concerned about, again, one of the problems is there's no good studies. The studies were done in healthy people, not in people who have cancer. So we have to take basic principles and then try to apply them. We don't have data on people who have bone marrow transplant. We don't have data on people who have had B-cell malignancies. Those are the folks that we worry that these vaccines may not be as effective as they would be in people of the same age and general health of folks who haven't had the malignancies or the treatment for malignancies. And that even makes the social distancing, masking, and hand washing even more important. My recommendation is not that they not get the vaccine, but they talk to their doctor and figure out when they can get the vaccine safely. But still, because the vaccine may not work, social distancing, masking, and hand washing of that individual and the people around them is very important. Remember, I wear a mask to keep from infecting other people, and those other people wear a mask to keep from infecting me. The mask, we now know, does offer some protection, but the biggest reason to wear a mask is to protect the people around you. And the biggest reason for people around you to wear a mask is to protect you.
Okay, thank you. So now let's talk about, can you just tell us a little bit more about the basic differences between the types of vaccine, both in terms of how they work and how effective they are? The messenger RNA and then the J&J and AstraZeneca ones.
The Pfizer vaccine and the Moderna vaccine are messenger RNA wrapped around with lipids wrapped around the messenger RNA. And is messenger RNA that when decoded codes for a protein that happens to be the corona spike that gives the virus the name coronavirus. Those spikes that you see, and those spikes in the virus attach to angiotensin converting enzyme receptors in the lung usually, and that's how they internalize in the body. Well, the messenger RNA codes for a protein that's the same protein on the spike, and it teaches our body that is the enemy. If you see that, attack it. And so when a person who is vaccinated with the messenger RNA vaccine, their B cells and their dendritic cells, which is another type of immune cell, are all on the lookout for this enemy. So if you come in contact with any coronavirus where the spike protein has that particular protein, your immune system will jump on it very quickly before the vaccine has the ability to gain foothold and start growing more and more virus in your body. Now, the Johnson & Johnson vaccine is more of an adenovirus-based vaccine. Again, it's going to cause your body, it's going to train your body that this is the enemy, this protein on the spike is the enemy. So as soon as you see this, lots of immune globulin or lots of antibody is made by your B cells to overcome and wrestle that virus down before it has time to start replicating and growing. And viruses grow 1 to 2 to 4 to 8, and they can grow very, very fast. The AstraZeneca Oxford vaccine, which is used in the UK and Europe, but not in the US right now, is also an adenovirus vaccine. It has to be used twice, though, by the way, two injections. The J&J is really wonderful because refrigerator storage, 1 injection. You don't have to come back 3 or 4 weeks later for a second injection. But all of these vaccines are teaching the immune system, this is the enemy. If you see this, go attack it. Now, you've heard about these variants. There's a variant in the UK, and there's a variant from South Africa. These are mutations, changes in the outer protein in the spike, so that the virus looks a little bit different. But we've got pretty good indication with the UK virus and some indication even with the South African virus that our immune systems aren't fooled that much. With the UK and the South African virus, the data right now seems to be that people who are vaccinated might get, especially the South African virus, and get some sickness to it, but the likelihood of severe sickness is much less. Now, the J&J vaccine, which everybody says is 65-70% effective, I can't overemphasize, it was tested in an environment where some people had the South African and the British variants of the virus, as well as the kind of virus we have in the United States, whereas Moderna and Pfizer were not tested in those environments. So when people say, I don't want J&J because it's only 65% effective, they may be doing the wrong thing. It may be a better vaccine than Moderna or Pfizer. We just don't know. The one thing we do know is people who get all three of these vaccines are less likely to end up in a hospital and less likely to end up dead.
Okay, so that leads to my next question. So is the advice then from President Biden and his public health team to just take whichever vaccine you're offered as soon as you're offered? Is that the right advice? And is there any, are any of the vaccines better for cancer patients based on their treatments or their cancer? Or I think you said we don't know, but.
At this juncture, we don't have data to show that any vaccine is biologically better for cancer patients versus another. I personally think that the J&J vaccine, if approved, might be better because it's only one shot. It's not better biologically, it's just easier to administer in a treatment regimen. But we don't have evidence that one is better than the other. My advice is get the vaccine that you can get. I would advise, if you get Moderna as a first shot, try to get Moderna as your second shot. You get Pfizer as a first shot, try to get Pfizer as the second shot. However, the CDC has said if you're in a pinch and you got Moderna and there's no Moderna available for the second shot, it's okay to get the Pfizer or vice versa. But all of us would prefer people stick with the same vaccine.
Okay, so that leads me to a question about the recent research that suggests Pfizer vaccine has a very strong efficacy after a single dose. Should there be a review of that with the possibility of changing the recommendation to a single dosage instead of two?
For Moderna or Pfizer?
For Pfizer, either one of them, yeah.
Yeah, the very interesting question. There's a lot of data that show that people who get one Moderna or one Pfizer have a huge antibody expression as a result of the first vaccine. The problem is we've got now 6-7 month data of people who got Moderna and Pfizer with 2 doses. And we know that they still have antibody and they still have high immunity against the coronavirus. I don't know if the second dose is the reason they have immunity 6 to 8 months later. Is it possible that one dose gives you great immunity and that immunity lasts for 3 or 4 months and then it goes away? Study not done yet. We'll eventually know that. Right now, the recommendation is that everybody should get 2 doses of Moderna or Pfizer, 1 dose of J&J. If J&J is approved, I do expect that they're going to get an exceptional use authorization within the next week to 2 weeks.
Okay, so you mentioned that the benefit of the single dose vaccine, that it's easier to administer, we can get it to more people quickly. And that even though the efficacy percentage is lower, it may not actually be lower. But if it is lower, do we risk further exacerbating disparities in outcomes if we're kind of focused on people in rural areas or underserved areas getting the single dose because it's easier to administer? But if it turns out to be less effective, are we potentially exacerbating those disparities?
If it turns out to be less effective, we will be exacerbating those disparities. You're exactly right. But on the other side, I do a lot of health disparities research. very frequently the problem with disparities is drugs are not refrigerated appropriately, or drugs are not mixed or thawed out appropriately. And I worry about how complicated it is to get the Moderna virus to people in rural settings. I've actually seen how complicated it is to get sophisticated chemotherapy to people in rural settings, or even the people in some of our larger overrun county hospitals. And so, yes, your question, I'm going to give you a non-Washington answer to your question. The answer to your question is yes. If Pfizer turns out, I'm sorry, J&J turns out to be not as good as the other vaccines, we might be causing a group of people who are poor, who are rural, to get a worse product. But it's an if right now. I am not convinced J&J is a less optimal product than Pfizer or Moderna. It may even be better.
Mm-hmm. Okay, that's helpful to know, because I think some people will get stuck on those percentages and want.
Yeah.
And so basically, whatever you can get it.
Yeah, I cannot overstress the J&J vaccine that got us that 65 to 70% was tested in a population that had the UK and South African and US variants of the virus. Moderna and Pfizer were tested in a population that only had the US variant of the virus. So it's fair to say Moderna and Pfizer were 95% in September and October. They may not be 95% in February and March.
Okay, makes sense. So as the vaccination effort has progressed, have cancer care providers changed their thinking about providing the vaccines? And as a matter of policy, should we as patient advocates be encouraging the distribution of vaccines from the government to cancer care providers so that they can get their patients vaccinated?
Because some of these vaccines the cold chain is so important, the thawing out appropriately and the thawing out at the right time, at the right temperatures, because those things are so important, I think it's important that centralized groups of people who do the thawing out. Now, once they do the thawing out and the preparation, can they transport, the Moderna and Pfizer can be refrigerated for 6 to 8 hours at least. Can they be then transported to a doctor's office to be given? I think that's fine. Unfortunately, and this is one of the reasons why the US has such a high death rate compared to, say, Canada, Germany, or France. We have decentralized this, and you said it in your introduction, every state has different rules for how this vaccine is given out. In certain states, Georgia, where I live part-time, it was all done by health departments, not by drugstores, not by doctor's offices. It was all originally done by health departments. That may be changing a little bit now. In Maryland, where I also live, they're doing it at drugstores. They're thawing it out and distributing it to drugstores every morning and giving it out to certain people. In Illinois, 1C is different outside of Cook County, which is where Chicago is, versus in Cook County. So people in Cook County who have health issues like cancer are not getting the vaccine, but next door in DuPage County or the rest of Illinois, they are eligible right now.
So there were a couple of resources we came across that I'm going to ask my NCCS colleagues to copy these into the chat. One was a Kaiser Family Foundation looked at different states' policies on who gets the vaccine, and then National Public Radio did a tool that lets you put in where you live. And what they tried to do was drill down to be a little bit more specific rather than, I live in Texas. And if you go to the Texas Department of Health website on COVID, it's going to give you a lot of information, but it may not be as specific to your area. You still have to do a lot of research. So what they tried to do is create a tool to help you figure out if you're eligible, and if you are, where you can get it based on where you live. I haven't tested it enough to say it's the best tool out there, but they said they had 12 researchers working on this, pulling together that information. So we'll share that link because that might be helpful for people to know. Also to know, like, if I know that some people, were looking at, like, CVS supposedly has it, but they don't have it in your area. So you can spend a lot of time looking on websites trying to find it. So we'll share those links and hopefully they can be helpful. But I think that's, one of the issues is that it's, people I know have spent many, many hours trying to find it, trying to get an appointment, refreshing websites, trying to get in. And then that leads to the question of, what about the people who can't do that because they don't have the internet access, because they don't have the knowledge to do that or the time to do that. And that leads to, questions about who is getting vaccinated and who is not. And I'm wondering, when you look at the data, do you see any encouraging trends about getting Black Americans vaccinated? Because we talked about the disparities in the outcomes and the higher drop in life expectancy. And then do you have advice about what we can do and how to be sure that Black Americans who are cancer survivors are getting the vaccine?
Yes. Well, by the way, the drop in life expectancy in Blacks and Hispanics is primarily because Blacks and Hispanics have high rates of COVID. And they have high rates of COVID because they disproportionately work jobs that don't allow for social distancing. The data that I have is it varies around the country. I personally think that we shouldn't worry too much about Black hesitancy to take the vaccine, that as more and more people take the vaccine and do well after taking the vaccine, Blacks and others who are hesitant to take the vaccine will start getting in line. They just don't want to be first. And I totally understand their concerns. I totally understand their suspicions. I've been outspoken that we in medicine have worked long and hard to deserve some of those suspicions. But I, along with 49 other Black members of the National Academy of Medicine, recently filmed an advertisement encouraging people to get vaccinated when their turn comes. So I'm very pro-vaccine. But I think we should be patient with the folks who are hesitant to get the vaccine. Most of them, I think, will eventually come around to, I want to get the vaccine.
Okay. And then, while some cancer patients are clamoring for access to the vaccine, there's a lot of who are still skeptical, regardless of race. One person shared when she registered with her comments or her questions, she said, I have many underlying life-threatening illnesses. I'm thinking by getting a vaccination, I might not survive. This is my gut feeling. What are some ways or trusted resources or ways to help cancer survivors feel comfortable getting the vaccine? Because even, advocates we've talked to who are, knowledgeable about research and clinical trials still feel some hesitancy. And even, how could it have been approved so quickly? It's taken, we don't have treatments for cancer that come this quickly. So how could we have this vaccine so quickly? So what are some ways to help educate people and get them? I mean, I hear what you're saying about when they see people getting it and doing well, that will help them. But are there other things that we can be doing?
Yeah, well, the education, I think, is the most important part. And folks who are hesitant to get the vaccine, while I respect their hesitancy, I'll tell them everyone that I've talked to who's gotten the vaccine is of the belief that getting COVID is far worse. And having talked to people who've gotten COVID, getting COVID is far worse than getting the vaccine. Now, that being said, there's a lot of people who say, how is it that this vaccine was, the virus was discovered December of 2019. We had a vaccine candidate by May of 20, and now we're giving it, you said 19 million people have gotten both vaccinations completed. Well, let me explain. It didn't take 6 months to develop that vaccine. It took 50 years. And those of us who work in the world of cancer and oncology should be able to understand this. Much of the science that went into developing the vaccine and understanding this disease were things that were developed in the war on cancer. And it's very much related to Richard Nixon signing the National Cancer Act in 1971. You know, the fact that we had a problem and a problem in China, within 45 days of realizing that problem in China, they published for the world on the internet the RNA sequence. The fact that we use these messenger RNA viruses, those were developed 20 years ago in cancer work. Some of the drugs, the recombinant DNA, the recombinant antibodies, the remdesivir to block replication. These were all things that were all developed out of cancer work. And so one can really say it took a long time to develop the vaccine because a lot of the work was done well before we actually knew there was a virus out there. And I've looked at the studies. The studies have been done very, very well. There's an argument that the Moderna and Pfizer vaccines have been researched better than most drugs that are approved.
Okay, thank you. I'm having a camera problem, but I'm going to go ahead and ask my question, not on camera.
Okay.
What about the hesitancy of healthcare workers to have the vaccine? That's something that I just don't understand, but I've seen a lot of reporting about it.
I understand it. I think, again, we need to be patient. We need to not force anybody to take this vaccine. I think over time, people will start realizing that the vaccine is much better than the virus. And, but yeah, I've seen a large number of healthcare workers. They tend to be healthcare workers that are more the blue collar, I hate to say less educated, who are concerned about it, not the doctors and nurses as much. But yeah, I totally understand the hesitancy. And again, I preach patience and education.
Oops. Okay, so what do we know about allergic reactions to the vaccine? At one point, advice was for patients who carry an EpiPen to avoid the Pfizer and Moderna vaccines. Does that remain the advice?
Yeah, there is everyone who has an EpiPen or a history of allergies needs to talk to their own physician. But there have been very, very few deaths due to, very few allergic reactions due to the coronavirus vaccine. As we've been looking for this, one thing that we found is there's less allergic reaction due to the Moderna and Pfizer vaccines than there is due to the influenza vaccine or due to a number of other vaccines that are out there. For example, the shingles vaccine has many more allergic reactions associated with it. Literally, there was a point when there had been almost 6 million people who had been vaccinated with Moderna or Pfizer, and there were only 7 documented allergic reactions, very small. And so that turns out that our concern about allergic reaction was a lot more overblown than it should have been. Now, I tell you, about 20% of people who are getting Pfizer or Moderna's vaccine, when they get especially the second vaccination, will have pain in the arm, sometimes some redness and swelling in the arm. They will feel a headache. They may get 12 hours later muscle aches and fever and kind of feel flu-like. We're telling most people here at Hopkins, when you schedule your second shot, do it on a day when you're not going to be working the next day. Plan on taking the next day off. It's about 20-25% of people who feel the medical word that somebody gave me was icky. There's about 20-25% of people who, when they get their second shot, just don't feel good the next day. and are going to hit the Motrin or Tylenol. That's not uncommon, by the way, with a lot of vaccinations. This one, the other way of looking at glass half full, 3/4 of people who get both shots have no side effects whatsoever.
So what about people who have a chemical sensitivity that the example was PEG, which are in the mRNA vaccines?
Yeah, those folks need to talk to their individual physician or talk to the people who are providing the vaccine. Those are the small group of people there's a small group of people who truly have those allergies who should not get the mRNA vaccine. They should perhaps wait until some of the other vaccines are available.
Okay. So after the second vaccine and the waiting period, what kind of socializing will be safe? What about mask wearing? Can we see grandchildren? That's not me. I don't have grandchildren yet, but that's what our questioner asked. And somebody else asked a question about the mask wearing because she had concern that people were not wearing it when they're supposed to still be wearing it even after they have completed their vaccinations and that waiting period.
I believe that people who are aware, and the CDC currently recommends that people who have been vaccinated still wear masks, social distancing, and hand washing. Keep in mind, the vaccine is not 100, it never was 100% effective. And with the British and the South African variants now in the United States, it's probably less than 95% effective for Moderna and for Pfizer. So I recommend that people who have been vaccinated first feel a little bit more relief, but don't let your guard down. And there's some people who said if you're in a group of folks who all have been vaccinated, you can let your guard down a little bit more. I'm a little worried about that because early in this conversation, I admitted to you, there's some people who get vaccinated and the vaccine just doesn't work for them. I worry especially about people who have B-cell disorders. And so I think that those of us who are vaccinated still should do the socially responsible thing, wear a mask, do as much social distancing as possible, and wash our hands. Now, seeing the grandkids from a distance, let's do it from a distance.
Okay. So using your crystal ball, does it seem like we're going to need COVID vaccines more frequently? Will we need both booster shots or annual shots going forward for the vaccine after this first dosage?
That's a really hard question to guess. If I look into the crystal ball, I usually look into the crystal ball by looking back. The 1918 influenza pandemic, which was an H1N1 influenza, different kind of virus. It stayed with us until about 1930. It got less and less by 1920, but it didn't peter out for 10 years. That may happen with SARS-CoV-2, especially if we start having more and more mutations and have more and more variants, and the variants get ahead of our vaccine. Now, many viruses mutate. They usually, as they mutate, get less aggressive and less deadly. We had a pandemic around 1200 AD, and the pandemic just got much better. And it's speculated it's because the virus that was the source of the pandemic mutated and became essentially its own vaccine. It continued spreading to people, but not making people sick. And so the one that was deadly got killed off. And so I anticipate, long-winded answer, I anticipate that we're going to be in mass until late this year, early next year. We may very well, those of us who've already been vaccinated may very well have to get a booster shot with other RNA. The FDA yesterday just published guidelines on what they're going to require in order to approve or give an emergency use authorization to a booster shot that might be to other proteins. We may be getting coronavirus vaccines every year the way we get flu shots. Flu shots, by the way, mutate every year. That's why you have to get a different kind of flu shot every fall. But I don't know. My guess is we're going to have to get a booster shot. And I'm kind of hopeful coronavirus will die out over the next year or two. But that may be very optimistic.
Okay.
How's that for telling you I don't know?
Well, it was a very, it sounded a lot better than I don't know, because it sounded like there was a lot to it. Some people have said we're going to reach herd immunity sooner rather than later because so many more people have had COVID than are reflected in the official numbers. What do you think about that? And even if we reach herd immunity, what does that mean for cancer patients or cancer survivors? And I mean, what's the difference between herd immunity as a population condition versus an individual's risk and whether they should get the vaccine?
Yeah, that's my dear friend, Dr. Marty McCary. He's on faculty here at the Johns Hopkins School of Medicine and the School of Public Health, as am I. Let me say that almost all of my colleagues here at Hopkins disagree with Marty on this one. He predicted that we'll have herd immunity by sometime in April of this year. Herd immunity is a point where so many people are immune to the virus, either because they've already had it or because they've been vaccinated, that the virus is having trouble jumping from one person to another in order to stay alive. If you think about it, a virus, in order to continue existing, has to jump to a new host every week and a half to 2 weeks. Indeed, there's some of people who said, if we could really do this social distancing thing really well, all wear N95 masks and do it seriously for 4 weeks, if we could have gotten the shutdown, the original shutdown, if we could have done it really seriously for 4 weeks, we could have broken the back and the chain of transmission of this virus and fixed the problem early on. Unfortunately, that's hard to do in a free society. Most of us think the best way to get herd immunity is usually somewhere around 70 to 80, 85% of the population immune. It varies depending on virus. For this one, we think it's in the 70s. Most of us think the best way to get herd immunity is for as many people as possible to get vaccinated and try to get them vaccinated as quickly as possible so everybody holds their immunity. 70% of people immune for 4 or 5 weeks. The reason I say that is we don't know how long the Moderna or Pfizer vaccine is going to provide immunity. It may work for 9 months, it may work for a year, it may work for 10 years. We don't know that yet. That study is ongoing.
Okay, so let's see. I still have some more. Some I feel like we've answered, but I want to get to a few others. Is there anything in the vaccines that can cause cancer or increase the risk of a recurrence of cancer?
I know of nothing that's in any of the vaccines, be we talk about Moderna, Pfizer, Johnson & Johnson, or AstraZeneca, Oxford. I know of no way that we can even theorize that the vaccine would cause cancer. And so for that one, I can be a little reassuring. I'm fairly certain that all of my colleagues are going to agree with me that these vaccines really don't cause cancer. Now, on the other hand, what are some of the side effects of coronavirus? I want to point out, I think I mentioned this in a previous interview, we were finding out side effects of the H1N1 influenza of 1918 in 1952, 1953. That's when they published that people who got the influenza in 1918 were at higher risk of having Parkinson's disease. Found that out 30 some odd years after the epidemic or the pandemic. What are the long-term effects of this virus? What are what's going to happen to long haulers in terms of there's some cardiac events that are already happening. There's problems with people thinking, foggy thinking. I don't know what the long-term effects of coronavirus infection are going to be. And I can't predict what we're going to find those long-term effects are in 10, 15, 20 years.
Okay. What about, does being asplenic have an effect on immunity, and does gut bacteria play a role in efficacy of the vaccine?
Gut bacteria, we don't know. Asplenic does change one's immune system dramatically. And for people who are asplenic, I would talk specifically to your physician before you get the vaccine. My suspicion is they're going to say, go ahead and get the vaccine. But I would talk to the physician. There are some things in my mind where I could speculate that being asplenic might mean that you have a less robust response to the vaccine. It may not work as well in the asplenic versus those who have a spleen. That's a may, not a definite.
Okay. What about kids? When will the vaccine be available for kids? How important is it going to be to get kids vaccinated, given that they're not very effective transmitters? And is there a reason to prioritize childhood cancer survivors over other kids when we do get to that point?
We are doing the bridging studies right now. Bridging studies are when you do approve something or prove something works in adults, you then start doing studies to figure out if they work in kids. We want to make sure that the vaccine is safe and effective in adults before we start looking to see if it's safe and effective in children. My gut feeling, and this is an opinion, this is not based on any science fact, is that childhood cancer survivors in childhood should be prioritized ahead of other kids. However, one of the most common cancers in childhood are those leukemias and lymphomas that affect the immune system. So we need to be very cautious there. Now, childhood cancer survivors who are adults should, I think, definitely get this vaccine right now. That's a group of people that is growing in size, by the way. And unfortunately, the average childhood cancer survivor who is in their 20s or 30s has 5 different comorbid diseases related to the treatment that cured them or the disease that they were cured of. And so this is a population that has a lot of comorbid problems. They, in my mind, definitely should be prioritized early amongst adults to get this vaccine.
Okay. Is it correct that screening mammography should be postponed after the second vaccine to prevent false positives?
Oh, this is a great question. This is a great question. There have been a group of people who have gotten the COVID vaccine and have felt a lymph node in their armpit afterwards. I don't know anyone who has had an abnormal mammogram after getting a coronavirus vaccine, but I have known several women who got the vaccine and then a week later felt something under their armpit and were scared that they might have a metastatic breast cancer. And so I would caution people who might feel something under their armpit to not panic. Still go talk to a doctor, but don't panic. And I am told that there is a possibility of an abnormal mammogram after a COVID shot. So I would delay the mammogram by a couple of weeks.
Okay.
That's a wonderful question. Thank you.
Good. We had a couple people ask. I kind of combined them into one. We have more questions than we'll get to in the next 5 minutes, but I'm going to try to get through a few of them. Does the vaccine cause an inflammatory response in the body? And if so, how does that impact someone with inflammatory cancer?
It does cause an inflammatory response. It revs up your B cells. It revs up your B cells, and then which is an immune issue. Now, it doesn't worsen inflammatory breast cancer, for example. So there are certain types of inflammation. The other issue, by the way, is most people who die of coronavirus don't die of the virus themselves. They die of the inflammation as their body is trying to combat the virus. Their body is really collateral damage as their body tries to combat the virus. That's one of the reasons why the IL-6 inhibitors like tocilizumab have been very useful for people who are in the intensive care unit. High doses of Decadron have been very useful. It actually blunts the inflammation at that point. I don't worry too much about the vaccine. Getting back to your question, I don't worry too much about the vaccine setting off the immune system and causing the immune system to go out of control. But the vaccine works by training the immune system. This is the enemy. When you see it, attack it. And those of us, I was one of them, who have the 20% who get their second vaccine and then have a really bad day the next day. That's your immune system attacking the vaccine, meaning that your immune system has learned its lesson very well.
Okay, thank you. So what do you have to say to states and municipalities that aren't allowing people in active cancer treatment to get the vaccine if they're not in the right age ranges?
Yeah, I don't know what the exact answer is when you have something that is in very short supply, something that the answer is you don't get into this situation in the beginning. We were promised by the administration in July and August that they were going to take a gamble and order enough vaccine such that all of us would be able to get vaccinated in January and February. All of us, not just medical professionals or a few people who are in category 1A and 1B, and that did not happen. Now that has happened, I don't know what the right answer is. I'm actually kind of glad. I once served on a CDC advisory committee. I'm glad I'm not on this advisory committee that has to weigh all of these things when you have a shortage. And I will say it is really unfortunate that the answer, can cancer patients get the vaccine, is different in one state versus another state. I think that's terribly unfortunate and terribly unfair.
I can see that some states, states have to look at their populations and where they have the most need. But yeah, it is a pretty big discrepancy in terms of how different states are handling it. If you have an autoimmune disease in remission, taking the vaccine have an impact, cause the autoimmune condition to resurface?
Depends on the autoimmune disease. I don't think we have data on that, but practicing theories, it depends on the autoimmune disease. You need to talk to your doctor about that. Some people who have certain autoimmune diseases are told do not get vaccinations. Okay, it really depends on what that disease is. And so that's got to be very much individualized. And then there's certain people who should not get live virus vaccines, which none of these are live virus, by the way. Yeah.
Okay. Yeah, I mean, we did get a lot of, and we try to get through as many as we can, but it's almost 4:00 and I want to respect everyone's time. So many questions that were really specific to a diagnosis or a treatment interaction. And so I think those are going to be really important to talk to your doctor about, even if your doctor's not the one who's going to be able to administer the vaccine because they're going to direct you somewhere else. They're the ones who can tell you best, if they're based on your specific cancer and your specific treatments and medical history, if there's any concerns. Thank you very much, Dr. Brawley. Do you have any kind of concluding words you want to say about, I know we've gone through a lot of questions,
Well,
and thank you so much for helping share answers on these topics.
I'm not finished with what Ellen Stovall taught me a long time ago. The most important thing that a cancer patient can do is talk to their doctor and force their doctor to talk to them and understand their disease. And if you have questions, ask those questions. The stupid question is the question that was never asked.
That's right. And that's being a self-advocate. And that is right. That is what Ellen taught us, and what I think so many of our advocates have learned how to do. And you do have to advocate for yourself and ask those questions. But I think you've helped us so much understand what we're dealing with and answer a lot of big questions. And then people can talk to their doctors about those specific questions. So thank you very much for your time. You're always so generous with us with your time, but you explain things so well that even those of us who don't have the medical background or scientific background can understand it. So we really appreciate you and your time, Dr. Brawley.
Thank you. It's a privilege to talk to you, and thank you for all the wonderful work that NCCS does, and you personally.
Thank you. And thanks to our team at NCCS and to everyone for joining and for all the great questions. We had so many great questions. I'm sorry we couldn't get to them all, but we did try to address as many as we could. And we really appreciate people joining us today. Thanks a lot and have a great day, everybody.